Sveiki dar kartą.
Good afternoon. We will switch to English.
I have an honor to introduce our next speaker, Professor Ellen Townsend, a lecturer and researcher from the University of Nottingham, United Kingdom. Professor Ellen has a lot of expertise on the topics which are very important and not so easy to understand. Self-harm and suicide among young people. Also, Professor Ellen has developed very interesting methods for the understanding and helping young people. So let's hear her talk. We apologize for a slight technical issues, but now we are on. So hopefully there will be no issues again, and the presentation will be heard smoothly. So again, Ellen, thank you that you agreed to participate, and we are more than eager to hear you.
Thank you. Can you hear me okay?
Yes, perfectly.
Can you see my screen? I'm going to put it on. Can you see that full screen now?
Yes, we can.
Fantastic. Thank you very much. Well, it's a real delight to be here today. Thank you very much for inviting me to come and speak about our work. I lead the self-harm research group at the University of Nottingham, where we're a mix of clinicians and academics, all interested in the psychological and social factors that lead to self-harm, and particularly in young people. That's an area of development that we're especially interested in. So we're interested in the psychological and social factors that lead to self-harm. We're very interested in what might help people with self-harm to cope with their distress and to stop self-harming or reduce self-harming. So we're interested in what works or what doesn't work in terms of interventions that we already have in the literature. So we conduct systematic reviews, and also developing new interventions and evaluating those, and with a very, very strong focus on involving people with lived experience, so who have experienced self-harm or suicidality. So what I'm hoping I'll talk about today, I'm going to say something very, very briefly about terminology. So what we mean by the term self-harm and how that slightly differs around the world. I'm going to say something extremely briefly about the scale of the problem. And then I'm going to spend quite a bit of time talking about the complexity of self-harm. And that's something that our group has been trying to grapple with over the last 10 years or so. Then I'm going to say something about the literature on the effectiveness of particularly psychological interventions for self-harm. And you'll see that there I'm really trying to stress that when I talk about patterns of suicide, of self-harmful behaviour that we observe in our work, looking at the complexity of self-harm through this new task that we have developed called the CaTsCo task for self-harm, or the CaTs. What emerges from that research is very encouraging in that the key transitions, the key thoughts, feelings, events and behaviours that move young people to self-harm are modifiable. So that's really encouraging. And I'm going to say something about the issues that we face in accessing treatment and in delivering treatment. And I'm talking from a UK perspective, but this is a problem globally, accessing the help and support that is needed for someone who is struggling with self-harm. And then I'm going to briefly reflect on the importance of involving people with lived experience of self-harm in research, particularly on interventions. We try to do this in our group as much as possible, so that the work that we do is both appropriate and meaningful for those who are self-harming. So that's what I'm hoping to do in the next, hopefully less than an hour. So there'll be plenty of time for discussion and questions. So when I talk about self-harm, I'm referring to any act of intentional self-poisoning or self-injury, regardless of suicidal intent. So this is taking a dimensional approach to understanding self-harmful behaviour and seeing a range of behaviours on a scale that is dimensional rather than dichotomous, or you have intent or you don't. And there is a literature emerging on this topic which shows from taxometric analyses that a dimensional approach to understanding this concept is probably the most accurate, although it is very, very contested in the literature. But that's where I'm coming from today. So any act of intentional self-poisoning or self-injury, regardless of suicidal intent. So one of the things I've spent quite a lot of time trying to communicate in my work, my research, and through the presentations that I give, particularly to frontline workers and people working in policy, and in people working in terms of commissioning treatments and intervention, is that it's really past time that people take self-harm seriously. It's a really important construct. We've seen from the work of Becky Miles and her colleagues in Bristol in the UK that self-harm predicts that really important transition from thinking about hurting yourself to actually acting on it. Okay, so the kind of behavioral inaction pathway is something that's really important in our field and has received quite a lot of attention over the last few years, and rightly so. And so self-harm is a really important element of that. And the Mars and colleagues were actually looking at non-suicidal self-harm. So that would be the equivalent of NSSI in sort of North America. So it's very, very important in that transition from thinking about hurting yourself to actually acting on it. We see from data in the UK and all over the world that self-harm is the strongest predictor of death by suicide. So for me, I think that represents a really unmissable opportunity for suicide prevention. So if we can help people who are struggling with self-harm, then we can make a difference in terms of suicide prevention. And also to say that it's not just linked to suicide. So we see data linkage studies showing, for example, that those who die from any cause of death, there's a reduction in terms of years of life loss, of 40 years of life loss on average. So this leads to significant premature mortality across the board. And unfortunately, in our country, and I suspect in many countries around the world, despite the seriousness of these issues and the really enormous impact that it has on people's lives, there's very, very sparse funding in this area. So it's something that we need to take seriously, and we probably need to also spend more money on in terms of funding. We've seen a rising tide of self-harm in the UK. In fact, these are data from England, from the adult psychiatric morbidity study, which is the upper end of adolescents. And I'm mostly going to be talking about adolescents today. So if we think about adolescents ending at the point where the frontal lobes are fully formed, around the age of 24, 25, this would be at the upper end. And you can see from this graph that we've had a very significant increase in young women self-harming and a smaller increase in young men. And this was before the pandemic hit. And obviously there has been quite some concern about what might be happening with self-harm and suicide with the pandemic and associated restrictions. And we've seen quite an interesting pattern of helplines reporting enormous demand on their services during the pandemic and lockdowns, whereas presentation to hospitals for self-harm actually decreased or stayed the same. So this has been hypothesized to represent unmet needs in the community generally in the UK. And I suspect that there might be similar patterns around the world. So let's think about the idea of complexity, which I think is extremely important when we try to work with self-harm. And you'll see from the variety of treatments that have been tried with people who self-harm that there is an acknowledgement that this is heterogeneous, multidimensional, and something that we have to have quite a nuanced and individual approach to at points. So here's a diagram, a figure from a paper published by Keith Horton and colleagues in The Lancet in 2012. And you can see here already quite a lot of complexity describing the genetic and biological factors that might be sort of background things that lead to troubles with things like aggression and impulsivity, perfectionism and optimism, which might be more kind of personality factors, which might feed into psychological distress and hopelessness. And then if there's exposure to suicide or self-harm, either through someone that we know or through the media, and a method is available to hurt yourself, the outcome may be suicide or self-harm. And so when one first looks at diagrams like this, it would be completely understandable to be quite overwhelmed by it and think, oh my goodness, there are so many things, what on earth can, where do I start? But I always try to frame this complexity as opportunity. And so there are multiple points that we could make a difference in someone's life when they are struggling with self-harm. So we have treatments that help with issues like impulsivity and aggression. We have interventions that help with things like distress and hopelessness and suicide ideation. We can think about how we present information to the public relating to self-harm or suicide, and we can reduce the availability of methods. So there are many, many opportunities that we can, as clinicians and as a community, make a difference in someone's life. So we've been thinking for some time about how we could hold on to that complexity. Often in research, we know there are multiple risk factors and we have to be selective about which ones we can look at in one particular study. The issues to do with power and access to populations and samples, and also you might want to look at protective factors as well as risk factors. So we wondered, what would be a good way to do this? And we decided that a card sort task where young people could almost tell the story of their self-harm over time and what the thoughts, feelings, events and behaviours were that led to self-harm. And we did this in collaboration with an advisory group of young people who had lived experience of self-harm, and we were lucky enough to receive some funding from our National Institute of Health Research to carry out this work. And you can see I have some pictures here of some of the things that came up in sessions working with those young people. And they really did push us to think about things that we hadn't thought of to include in the task that was not evident in the literature from very high quality studies on self-harm, prospective studies. And so they made a really important contribution to the things that would be included in the task, and also all the way along the research process, actually, from shaping the research questions to then deciding how we should disseminate the information. And actually, one of the things we did with them, as you can see a picture of one of them here, talking about the results of the study and reflecting on it from their own personal experience. So we made some films with them about it. So with our task, we wanted to examine the thoughts, feelings, events, and behaviours that arise prior to self-harm and what happens after self-harm. And we used a particular technique to analyse the data from this task called sequence analysis. Excuse me, which allows us to determine what are the important sequences of factors that lead to self-harm. So what are the important transitions in that journey? Indeed, is there a sequential pattern to self-harm at all? And so in order to answer this question, we asked young people to produce a card sort based on their experiences for their first ever episode of self-harm and their most recent episode of self-harm. So here we have a very high-tech task, as you can see at this point, laminated cards, which are presented in piles of cards relating to thoughts, feelings, events, and behaviours. We had 117 cards in the original task. As I said, these were selected from high quality prospective study results, important theories that have been tried and tested in our field. And the idea is that young people map out what happened before self-harm and then what happened afterwards. So at the top you can see there are some timestamp cards. These are the slightly larger cards going from 6 months before self-harm, leading up just before, and then self-harm, and then what happens afterwards. And so people are asked to put the cards that related to their experience personally in order. And so the ordering is really important. So they have to think, you know, what led to what led to what led to what. And so you end up with this sort of very long kind of snaking journey leading up to self-harm and then what happens afterwards. Now, we also had blank cards. So the participants could add in any experiences that weren't detailed on the cards that felt particularly relevant to them, so that we could capture all this kind of rich information. So I've just got a zoom in here on some of the cards chosen in one sort, and you can see that there are some quite difficult cards here. And there's something about this task which allows people, I think, to use cards and to think about what has happened to them, and it sort of scaffolds that telling of the story, which can be quite difficult, I think, in assessment. And of course, they had these blank cards so that they could add in anything that we had missed in their own particular journey. So once we had captured data from, in this case, 45 young people who did the first study that we did on this, we analysed it using a technique called sequence analysis, which is really excellent to enable us to capture both complexity and temporal patterning over time, so that sort of sequencing. It's a really useful technique because you can see what's happened. You can use data that's happened in the past. And unless you're using a technique like echological momentary assessment, and even then you're asking people often to reflect on what's just happened or happened during the day, we're always dealing with events and things that have happened in the past, really. This technique also allows us to look at the complexity of the potential causal factors and the dynamic interplay over time. So it's exactly what we wanted in terms of being able to get a bit closer to understanding more fully the complexity of self-harm. This technique has been used in many different areas. So, for example, mother-child interaction. And the example that I have up here on the screen is of how people escape from a burning building. So you can look back and see, the thoughts, what happened during that process that led to either successful escape from the fire or not. So here we have the top 5 cards that were chosen to be used in the task on each occasion. So in one column, we've got the first episode of self-harm, and in the other column, we have the most recent episode of self-harm. You can see there's quite a bit of overlap. So the most common card chosen across those 2 time points was feeling depressed and sad. Also important was an idea of not being able to tell anyone how you're feeling. So this idea that you're kind of keeping all these very difficult emotions inside, and you just don't think there's anyone that you can talk to about that. And then we have cards relating to self-hatred, isolation, so keeping yourself away from other people, and worthlessness. And interestingly, in terms of the most recent episode of self-harm, that actually gets replaced with a sense of burdensomeness, so feeling that you're a burden to people. So those are the top cards. And so when we do sequence analysis, we can produce what we call a state transition diagram, which I have an example of here from the first ever episode of self-harm. And I apologise, I realise that the font is quite small in these little boxes. But again, I want to show you that this does quite a nice job of capturing complexity, although we did have to filter, do a frequency filter on the cards so that we could see the most frequently used cards. And so you'll see in the square boxes in this diagram, there are what we call medium frequency items and low frequency items. And again, that speaks to the heterogeneity of experience in self-harm. So within this box are lots of different things that that were important to that particular person. It's just across the group, they were not frequently used enough to make it to the kind of final analysis, if you like. Now, if we had a bigger sample size, we should be able to kind of explode those boxes out a bit more and include more of the the detail. This was our first study trying this technique, so we were a little bit limited with our sample size at this point. But anyway, just to highlight some of the key findings. So what we've got here are cards that came together, that we observed to be paired together more often you would expect by chance. And the bigger the arrow, the stronger the association. And the first question was, do we observe a sequence or pattern over time? Yes, we did. So these results are significant. And so you can see that the black lines are the ones which are showing the really, really strong relationships. I'm just going to pick out a few important things to highlight here. So the only card to be directly proximal to self-harm was some notion of impulsivity, so acting rashly or doing something, doing it impulsively without planning. And that was strongly associated to having the means in the environment to hurt yourself with. And then at point 3 here, we've got this, I guess, real collection, swirling vortex maybe of really difficult thoughts and emotions, feeling anxious, angry, worthless, and self-hatred and so on. At point 4, you can see, I think, something very clinically important, this notion of not being able to trust anyone enough to tell them how they're feeling. So this idea of just not being able to talk to anyone being very important. And then interestingly, at point 5, you can see that after self-harm, young people were saying for that first episode, they felt better. So there was something about the self-harm that had helped them to feel better than they had felt before they self-harmed. So that's the first ever episode. Here's the state transition diagram for the most recent episode. So some similarities and some differences, which I'll quickly talk through. First of all, at point number 1, you can see impulsivity. So I did it on impulse without planning. Again, being the most, the only factor that was directly proximal to the act of self-harm. And in contrast, previously, access to means was the only factor that led, was strongly associated with impulsivity, but now also self-hatred is also significantly associated with impulsivity. We still have these negative thoughts and emotions. We now have hopelessness creeping in as a significant transition, and also suicidal intent, so wanting to die, which was not evident as a significant transition in the first episode. And then again, in contrast with the first episode, we can see that this idea, this feeling better, has now disappeared. So that is now not a significant part of the transition of the sequence. So we were quite encouraged by these results and felt that this was moving us towards understanding complexity in ways that we hadn't before. And I think we remark in the paper that actually it does seem to fit quite well with the biopsychosocial models proposed by people like Rory O'Connor in his integrated motivational volitional model, where you have sort of biological factors which moderate into kind of personality factors, moving from ideation to action. So it actually maps quite nicely onto those kinds of models. And then young people told us that they really liked doing the task, and it almost felt like for some of them, they had light bulb moments. They could really start to understand how certain things led to other things, which moved them closer to the risk of a self-harm episode. So they got some really unique insights into their distress and what was happening to them. And so we started to wonder whether part of what they were doing in this task is mentalization. So it's the ability to think about thinking, helping us to make sense of our thoughts, beliefs, wishes, and feelings, and to link these to our actions and behaviors. So the task is a little bit like chain analysis in DBT, when you're sort of seeing what leads to what leads to what, but we're pinning it more to a kind of temporal dimension and scaffolding it with the provision of the cards to help with memory and so on. So we wondered whether this would be quite a useful tool to conduct interviews and to help young people when they're talking about self-harm. And indeed, just anecdotally, alongside our first card sort study, we had interviewed quite a number of the young people who took part in that study in a qualitative interview study as well. And the person who conducted those interviews was extremely experienced, very good at putting young people at their ease and getting them to talk about quite difficult experiences. And despite that, we found that young people who also took part in the card sort task told us more in that task. They placed cards down in the card sort task that they hadn't discussed in the interview. And we wondered whether there was something about using the cards which gave young people permission to talk about certain topics, and it was sort of slightly changing the dynamic of the interview process. So we tried this out. I say we, one of my brilliant PhD students, Dr. Joe Lockwood, carried out an interview study using a version of the card sort task in which she focused on impulsivity. So she really zoomed in on that key transition that we saw both with the first episode and the most recent episode. I did it on impulse without planning, and her PhD really did focus on impulsivity using a number of different methods and in different studies. So she developed the task further. She firstly created what she called an all about me card sort task, which were 25 cards and blank cards that the young people could use to best describe themselves. And many of the cards here were taken from theories and measures of impulsivity that they could ascribe to themselves. So here Joe's trying to gather individual experiences on the relationship between impulsivity, emotion, self-regulation, and cognition in the trajectory of self-harm through this interview study. And then she had a smaller, more condensed version of the card sort task, 43 cards, again with impulsivity constructs and things that we felt would be really important in relation to that, plus the blank cards that the young people could again add things to. And so, they sat side by side and discussed the sort, and the young people completed that themselves over this shortened time frame, so a much shorter time period leading up to the self-harm, because we're focusing particularly on impulsivity. And what Joe found is it really did afford a very nuanced dialogue, a really sort of side-by-side collaborative rapport was possible, and I think Joe felt that it really did reduce the power differentials that you sometimes experience when you're doing interview type studies. The young people really felt that it sort of helped support their understanding of what was happening to them. And again, we think that might be something to do with mentalization, but we need to do more research to understand that more fully. And I think it did help young people to really reflect quite powerfully on the meaning of impulsivity, emotion, and cognitive factors in self-harm as it applied to them. So they really saw benefit, the young people who took part in this work, in discussing the stages and the progression and change in relation to their self-harm. This multi-dimensional and complex understanding of impulsivity, which Joe had introduced, really made sense to them. And one of the really encouraging things that I felt about this study was, although the young people felt that they often had ascribed impulsivity as something that was, quite internal to them, they felt there was room for change. They felt that this was something that actually they could change about themselves. And interestingly, in the All About Me card sort, where they're talking about how they can describe themselves, the highest frequency cards was all to do with managing and tolerating negative emotions. Okay, so I'm now going to use the kind of framework of where we've come to with our card sort research to think about interventions and where we can target treatments to transitions that are modifiable, that we've seen to be important in this journey to self-harm. So what this slide is showing, with all the green covering our little boxes from the state transition diagrams, is that pretty much all those key transitions that we've observed, these are things that are modifiable. So there are things that we can do stuff about, like negative thoughts and emotions, through cognitive behavioral therapy, through dialectical behavioral therapy, through mentalization-based therapy, and indeed group regulation. interventions, emotion regulation interventions. And over the years, we've been conducting Cochrane reviews to see what interventions are helpful, both for adults and for children. So I'll just talk a little bit about that in the next few minutes. So this is work that has been led by Keith Horton since the late 1990s. So I've been working with Keith on this work since then as one of the postdocs involved in this work a very long time ago now, alongside Ella Alrinsman originally. Now, I think the first thing to say about this field is that there have been surprisingly few studies, few investigations of treatments for children and adolescents who are struggling with self-harm, despite the size of the problem of self-harm in many countries. And so in our latest version of the systematic review, which was published earlier this year in March, we included randomized controlled trials that had participants under the age of 18 randomized who'd self-harmed in the last 6 months of trial entry. The primary outcome that we focused on is a repeated episode of self-harm, followed up over a maximum of 2 years. And we had a variety of secondary outcomes that we were interested in, including how well people stuck with treatment, so treatment adherence, depression, hopelessness, etc. And the bottom line for this work is that there's currently no clear evidence for the effectiveness of a number of treatments like CBT or even mentalization-based therapy and so on. We just don't have enough trials to, we've got one positive trial, for example, mentalization-based therapy. But what looks promising now, with a number of new trials coming on stream, is dialectical behavior therapy, where we see a lower rate of self-harm repetition in those who have received DBT compared to treatment as usual or enhanced usual treatments, or an alternative psychotherapy. And that's based on quite good quality evidence. So it's really promising that, since we started doing this work, we do have more trials to work with, but it feels like not nearly enough when you compare to other fields such as anxiety and depression. There are far fewer trials in this area than in the adolescent and pediatric depression and anxiety literature, so we do need more. I'm just going to also reflect on the review that we've conducted for those over 18, because when you talk about adolescents going up to the age of 25 now, obviously the upper end of that group is included in this adult review. And historically, the reason we split it that way to begin with is the way that clinical services were structured in the UK at that time. There's probably an argument for changing it in future years. But here's the latest version of the adult Cochrane systematic review, which was published in April this year, led again by Katrina Witt. So here we're looking at participants who are over 18, who self-harmed within 6 months of trial entry. Again, the primary outcome is a repeated episode of self-harm over a maximum period of 2 years follow-up, and similar secondary data outcomes, including suicidal ideation, depression, and hopelessness. And so in this table, you can see the different types of interventions that show, I guess, promise in across some dimensions. So we have cognitive behavioral therapy, for which we have 10 studies showing that CBT reduces the number of people repeating self-harm. However, in 4 studies where the frequency of self-harm was measured, that was not a significant reduction in frequency. When we look at mentalization-based therapy, we have 1 study showing both a reduction in repetition and in frequency. And when we look at dialectical behaviour therapy, although the proportion of people repeating self-harm does not decrease significantly, 2 studies show that frequency of self-harm does decrease significantly. And then finally, in emotion regulation group therapy, 2 studies showing that the proportion of people repeating self-harm is decreased. And there are many more treatments now included in this systematic review. So still no clear evidence for a number of these, and that's partially to do with the number of studies within each comparison and whether there's enough power to detect results that look clinically meaningful, statistically. So promise, I think, in terms of interventions, but as the first slide of that section said, we desperately do need more interventions for young people who self-harm. I'm just going to reflect a little bit on some of the issues with treatment and access and delivery. So it's great that we have these interventions and that they seem to be useful, but if you can't access them, that is a problem. One issue that is a barrier off the bat, we think, we've seen it across our research and very, very strong through our CaTsCo task work, is this notion of help seeking. So we've seen it across many different kinds of studies, school-based studies, interview-based studies, and now the CaTsCo task, that young people just struggle so much to ask for help and to talk to people. And I have a couple of quotes here from some qualitative work that was led by Ruth Wadman with young people, and this was something that really was a very strong theme in that work. So finding it extremely difficult to talk to people, just can't do it, just don't trust anyone. And that really, for me, this really does highlight the importance of this transition that we've seen to be important in our CaTsCo work, that just not being able to trust someone enough to speak to them is potentially a huge barrier in seeking and accessing support. We have a problem in the UK with access to services and care pathways for self-harm within our statutory health system is very difficult and fraught, very variable across different parts of the country. So even when young people do seek help, it's very difficult to find it. And that means that many young people fall down between the gaps in services, and I have many times seen young people left with nothing at all. And sometimes they get sent away with no actual support, but leaflets about what they might do to look after themselves, and some of those leaflets, information, are more useful than others. We were really concerned about the number of clinical services recommending harm minimisation in our area. So we conducted a study, a mixed method study, to interrogate how helpful harm minimisation is to young people. So harm minimisation is a number of things, but the particular thing we were interested in this study was sensation proxies. So snapping an elastic band, drawing with red lines on yourself, using ice cubes, and so on. So the bottom line from this research showed us that very few young people found these methods helpful. That's not none of them. A few of them did, a small number did, but the vast majority of them felt that the methods that they were using were more problematic over time, and so they were choosing very large rubber bands which would hurt themselves. So it sort of turned into a form of self-harm. And we have a couple of quotes here from the qualitative element of this research, saying actually it's really not that helpful. There are no randomized controlled trials on harm minimization, so we really don't know about efficacy or effectiveness. A more recent study that was published in the UK on a clinical sample, again, found a small number of young people using it and for whom it was helpful. So I think we need to understand for whom it is useful and when, and that is what the authors of this most recent paper concluded as well. So I feel we need some more research in this area. And unfortunately, even when young people do manage to access services and supports for self-harm, they often encounter negative, patronizing attitudes or feel that services offer empty promises, leaving them feeling that they're not listened to and they feel let down by services as a result. So this is another qualitative study that we conducted led by Ruth Wadman, where we found young people really struggled with the clinical setting. Again, not all of them. Some of them found a great deal of support, and the right therapist had a very strong therapeutic relationship with them. So there are mixed views about the support they receive from our statutory services in the UK, and I feel there's quite a bit of work to do there. So the final thing I want to reflect on in the last few minutes is this idea of patient-public involvement, engaging young people, because that's the group that we're working with. But obviously, if you're working with older age groups, then they should be included too. So we have talking therapies, that's great. We could do with some new ones, particularly young people, but what should they be? And we have thought about developing our card sort task into an assessment tool, not least because we'd seen through both our initial studies that there seemed to be something quite valuable related to mentalization that young people were finding really beneficial. And so we took it to a focus group in a project that we call Cafe Connect, which is where we go into the community, into relaxed, comfortable settings, so not the big, scary university that has barriers and departments of psychology and psychiatry, and that's all quite stressful. But going into the community and finding a nice private space where we can have nice coffee and so on, and talk about where we see things developing with young people. And we took our card sort task to them and said, look, this is how we've been using it as a research tool. How could we use it, as a moving forward? And we got incredible feedback saying, this could be a really useful intervention tool. Could we make it into an app? Can we use it to track issues that are happening during the week? And then we talked to it with our therapist, and they kind of had all these amazing ideas. And for this project in particular, I had very little funding. So I was thinking, how can I make some of these things happen and test whether this could be something useful therapeutically moving forward? And so what we were able to do through that co-creation project was to get an electronic version of the card sort task online. So I had an amazing postdoc who was able to create the coding so that people could select from thoughts, feelings, events, and behaviours and drop them down and create a card sort online. This is something that we're currently writing up. And what we found, so we've extended the age range here. So we've included adults. The online version seems to work just as well. In the results, we see a sequential pattern. Again, impulsivity seems to be the key proximal factor right before self-harm, including for older participants as well. We did notice using this format that many more cards were added in the after self-harm portion of the card sort, so that's interesting. But it does demonstrate that this could potentially be a useful both research tool and assessment tool for adults as well. So we're very lucky that we've received some funding from the MRC in the form of a programme award, that we're going to be able to develop this work further as part of this programmer's work. So it's just one of 7 projects that are funded through this programme that I'm leading with Chris Hollis at the University of Nottingham, to see how we can support young people using digital technology. And we have several projects within the programme that are looking specifically at self-harm. Another area of development is to think about how we could use the task in collaborative assessment. So I've been doing some work with Dave Jobs and Amy Brausch, again thinking about how we can develop this tool more therapeutically. We've also been working with frontline staff to see if using the card sort could be helpful in training. So we've done this in 2 ways. So we've kind of asked therapists to put themselves in the shoes of young people and kind of create a fictitious card sort. And another thing we've tried is to give a kind of fictitious card sort to clinicians and say, okay, you're working with a young person, this is what they've done, how would you approach working with them based on this? And we're doing a bit more work on that in the not too distant future to see if that could be useful as part of training around self-harm assessment and prevention. So I've tried to say today, I think, that self-harm is serious, it's complex, and it changes over time. The good news is that the key transitions that we're finding in our research and seeing in the research of other people is that these things are modifiable. We can do things about them. Talking therapies are helpful, but we have to think about the barriers, particularly for young people. I think the development of new treatments and tools needs to include young people, and I'm happy to answer any questions about how you might do that, because I think different places are in different stages of how we go about doing that work. So in our MRC programme grant, we have 2 young people as co-investigators on the team, and we have an advisory group of young people that have been working with us for over a year to build up to the grant application. So we've really embedded engagement with young people throughout that work. So are we responding effectively to young people? I think we're getting there. I don't think we're being completely effective. I think we've got some good ideas that we need to build on over the next few years in collaboration with young people. So finally, just to say huge thanks to lots of collaborators around the world who have been involved in this work. They're not all pictured on this slide. And to our funders. And finally, just to say that we have a website, and unfortunately it's horribly out of date. We are trying to do something about that, but there is quite a lot of information about the card sort task if people are interested. So I'm going to wrap up there, and I'll be happy to answer any questions.
Thank you, Ellen. Very, very interesting presentation, and I guess that a lot of us, after hearing what you spoke about, gained a broader perspective on self-harm. And your method of CATS is really intriguing. And before I go to quite a lot of questions, can I ask you, is that method available? For example, if our researchers or clinicians would like to use or participate in research, could they use, is there any training? Could you specify a little bit about that?
Yeah, absolutely. So we have a version that we can send to people, which is a kind of PowerPoint with all the cards. And I also, I'm happy to share materials that I use with students who want to use this technique. I'm happy to do that. We don't have training. That's a good point, actually. We ought to think about that and think about how we could resource that, because I do get an awful lot. At the moment, it's a research tool and it feels very intuitive, and lots of people want to use it clinically, which is why we're trying to work as fast as we can to try and get this, sort of validated, and so that we can say to people, yes, it's fine to use an assessment, but certainly we can send people a copy of the task for them to have a look at and play with. Absolutely.
Yeah, thank you. That's a great news. So I will read some of our guest questions. Okay, so I will try to translate it. While working with adolescents, sometimes in order to help them, some alternatives for self-harm are sought. However, usually those efforts are with no results. So what is your opinion on trying to search for some alternatives for self-harm when clinicians try to help adolescents?
Yeah, I think that's sort of referring perhaps to the harm minimization work. So it's sort of replace, and it feels intuitive, doesn't it? It feels intuitive that if you're doing something, that's probably better than self-harm, and it might be a bit more beneficial than nothing. I suppose what I would say about that is, for me, it's focusing on the behavior too much. Self-harm is a behavior, but underneath self-harm is distress. Okay, so for me, it's about what are we doing to support the dealing with those really, it's emotion regulation, it's strong, difficult, negative emotions. How can we scaffold and support that? And harm minimization might be part of that for some people, but as the questioner says, it doesn't, may not work. So it's, but I understand there's a kind of difficulty, and I think where lots of people think this could be useful clinically is in that gap that I talked about, where if someone's a young person struggling, but they can't access services, maybe this is something that could be useful in the interim. I think we need to find different tools to support and scaffold young people in that period, because for me it doesn't get to what's underpinning, what's underneath that self-harmful behavior.
It's only a tip of an iceberg.
Exactly.
Okay, we have some more questions. There are a lot of thanks for the presentations also, besides questions.
Thank you.
So one of the questions sounds like this. In your presentation, you emphasize impulsivity, impulsivity without planning during the self-harm. And what about suicide? When people speak about suicide, usually they say that they are planned, they are pre-planned, they are not impulsive. What are your comments on that?
Yeah, I think there's still quite a bit of variety and variation, and I think particularly in relation to young people, and perhaps because I have my head in the kind of young person literature most of the time, that's what I spend most of my time thinking about. And so we do see young people doing, even with suicide, the time between thinking about it and acting on it is probably a bit shorter. Impulsivity is a really interesting concept, and I think we're at early stages in even understanding. Even there's a vast sort of literature on this in relation to self-harm. I'm just thinking about some of the access to availability of means literature, and how sort of putting barriers in literally physical barriers, so sort of on bridges, purchasing certain drugs. So, for example, in the UK, limitations on paracetamol, acetaminophen access, and it's kind of putting stopgaps in between. If someone is planning to do something, In the paracetamol literature, one of the drivers for that was the idea that a lot of people that had turned up at hospital for paracetamol overdose hadn't thought about it for very long. But you're right. I mean, the interesting difference, because I know that Thomas Joyner has got quite strong feelings about impulsivity in relation to suicide. And I think that would be something that would be really interesting, to explore a bit further. And I suppose, again, I kind of think about this continuum and self-harm. There is this very strong relationship to death by suicide, isn't there? So although we see these differences, they're probably, over time, what's that relationship?
Yeah, we get a lot of we get quite an impression that it's usually it's too complex to say that it's either impulsive or either pre-planned. In some research in Lithuania, we also tried to understand some pathways towards suicide, and there are some aspects related to impulsivity, some aspects related to planning. Usually, we get a feeling that it's quite difficult to draw a very strong line on that one. And like you said, self-harm, like in your presentation, after repeated episodes, suicide feelings emerge more and more. Yeah.
Yeah, I that's, so you see this sort of pattern of deterioration over time, if you like, which I think is really concerning. So it's interesting. I think the relationship between sort of urges and plans and intentions and so on is, I think there's a kind of gap in the literature there to understand the relationship between these things are quite a deal more. And obviously the problem with suicide is that you'd have to kind of construct it, based on, psychological autopsy type approaches. But it would be really interesting to try the card sort task with clinicians, for example, who've had a patient die by suicide, and ask them to sort of think back, what happened, and then we could see whether the impulsivity card was chosen at all, and maybe it wouldn't be. I think that would be really interesting. So if anybody wants to do that work, that'd be great.
I guess that was one of the reasons to ask you about the availability of a method, and quite
it's all free to access, all happy for everyone to use.
Great. And I also remember you mentioned something about negative attitudes towards self-harm. I also wanted to ask about, well, it seems that quite often in some settings, in correctional settings, in foster homes, it's quite often to see self-harm as some form of manipulation. There are quite strong negative attitudes towards self-harm. Could you tell your opinion about that? Could you elaborate a little bit?
Yeah, so there's a literature on it. There's a wider literature on it, and it's something that we've seen in our research. I think the good news is that with training, you can really challenge those attitudes, and so that's really positive. So even where those attitudes persist, with good training, and particularly involving people with lived experience. So I've literally seen, and that's the thing that often moves a room in training. So I can be up there and talk about all sorts of things and the theories and risk factors and all of that. But then someone with lived experience will stand up and say, this is my experience. And you can just feel the whole room change. And, that understanding that personal story is so powerful. I think training we need to do much earlier on. I think we need, and it's often very piecemeal. So often I say to my undergraduate students when they've had my lectures on self-harm and suicide that they've had now more training than many people, dealing with mental health patients on the front line, and they're kind of shocked by that. But we do have an issue that the training is not kind of embedded early enough in practice, perhaps. I don't know what your experience is in Lithuania, but we have very little here, very little.
I would say also that, I think the situation is improving. We have more and more trainings, but still there is some mountain to climb.
Yeah, yeah. I think people are very afraid. They're worried about doing the wrong thing, and so that kind of attitude is easy. It's sort of defense mechanism that you can just kind of dismiss someone because actually, if you thought they really were in this amount of distress, that would be quite overwhelming. So I think but the good news is that really good training can make a difference.
Yeah, yeah. Okay, I think we should stop now. So again, really thank you that your insightful and encouraging talk and your questions, and I hope that we could develop communication and collaboration, and some specialists, I believe that they will try CATS method. Besides, CATS, the name of the CATS is amazing. Cats are amazing. So
cats are amazing.
Totally.
That's not an accident. We all have cats in our group.
We do.
Brilliant. Thank you so much. Thank you for the great questions.
Thank you, and see you.
Bye.